Good evening. I am Dr. Fletcher, and I'm gonna talk with you today about assessment, diagnosis, and treatment of opioid-related disorders. This is my presentation. You can see that I work in opioid treatment programs and in OBOTS, and I'm a certified addictions registered nurse advanced practice and a fellow of the International Academy of Addiction Nurses. I have no financial conflicts to disclose. And the learning objectives are to learn about how to identify epidemiology, clinical course, and impact of opioid use, understand the neurobiology of addiction and opioid pharmacology, recognize the diagnostic criteria of opioid-related disorders, identify the signs and symptoms of opioid intoxication, overdose, withdrawal, and use disorder, evaluate treatment options, look at the guidelines, discuss strategies to address stigma and bias, look at the terminology in addiction medicine, and most important thing, to discuss the role of harm reduction and risk mitigation strategies. First, you need to know that opioid related disorders are a public health issue, and I included here information from the National Survey on Drug Use and Health in the United States. Concerning is that the most common reason for people to use is to relieve physical pain. So it's important to be able to work with that to help people relieve physical pain. However, the most concerning thing is that among the people who had a substance use disorder and did not receive treatment, 95% of people did not seek treatment because they did not perceive that they needed treatment. So we need to work on educating patients. Epidemiology is also concerning. The drug overdose death rate here included shows that has been some improvement. It decreased between 2022 to 2023, but this can be in a way misleading because we do not have all the data yet. There are some underreported deaths due to pending investigation and toxicology results. There have been three waves of opioid overdose. It started in 1990s with increasing prescription opioid overdose deaths, the OxyContin. Then it followed with increasing heroin overdose deaths in 2010. In 2013, there was an increase in synthetic opioid overdose deaths, which is fentanyl and its analog. And most currently, there is an increase in deaths involving fentanyl and fentanyl analogs and the stimulants. And I've seen it a lot. Lots of my patients are using stimulants combined with fentanyl. And most recently, there is xylazine that's mixed into fentanyl. Many people do not know that it is there. Bias, so the main perceived barrier to treatment is that people do not think they have a substance use disorder. There are other biases, there are other stigma, other reasons for not getting treatment, such as stigma associated with substance use disorder and readiness to accept services. And it's sad, but lots of people, lots of patients have stigma. They have their own stigma associated with how others think about them. Bias can be both positive and negative, conscious and unconscious, external and internal. Terminology is a new area in the addiction medicine, and it's very important to use medically clear, accurate, person-centered, and non-stigmatizing terminology. Most of people know that person first language is best to use. You would say a person with alcoholic use disorder, not alcoholic. But we got to be careful at everything we use. Lots of words right now are not correct, medically correct or accurate or person centered. For instance, misuse, you're going to see it in all the surveys. It's not a good descriptor. Because it implies a value judgment, you would say use other than prescribed. The same medication assisted treatment is not correct because medications are treatments of their own, like methadone or buprenorphine, and they do not assist treatment. A word that I use all the time is adherence. You don't say the patient is compliant, you say treatment on adherence, because compliance needs that patients do not have an active role. They comply accordance to someone else's wishes, rules, and regulation. And you want to emphasize the patient's collaboration. The patient is the captain of the team, actually. You are helping the patient to reach his or her goals. Abuse is not a good term either to use, and you have to look at a spectrum of use, starting to lower risk use to unhealthy use, which can be hazardous or at risk and harmful, which includes addiction and SUD and substance use disorder. But it's hard to change the words. Even institutions like SAMHSA, Substance Abuse and Mental Health Services Administration, or National Institute on Alcohol Abuse and Alcoholism have done the words there, and it's not that easy to change. It's really an act of Congress, and they are working on. Impact of opioid use. It's visible. It's like the iceberg. You can see some or you cannot see some. You see the morbidity, mortality associated with direct, like direct hospitalization, overdose, when people die of intoxication. But what not many people see are the consequences, the medical, the accidents, the violence, the increased criminal activities. For instance, I have patients who are using substance. They don't have houses to live in, and some of them prostitute to be able to get drugs. So there are a lot of consequences. This leads to high risk activities, the untreated addiction, and evidence show that the mortality rate is higher for the people who use opioids compared to those who do not use opioids because of all these other complications. And here is a word that is not correct, homelessness. We do not say homelessness. We should say somebody is unhoused, not homeless. Pregnancy, chronic untreated addiction is associated with risk to both the pregnant woman and fetus, and I'm going to talk later about that in more detail. Risk factors associated with opioid-related disorders are many, and it's a combination. Often there are genes, and we see that, for instance, with methadone. There are people who are extensive metabolizers because of genetic risk factors. Social people around them who are using drugs. Dysregulation of neurotransmitters, peer attitudes. But the course is chronic. Once it starts, there is some remission, and people just lose control over use, and it's not difficult to return to opioid use. And the American Society of Addiction Medicine got a definition of addiction, and it is a treatable medical condition involving complex interactions among brain circuits, genetics, and environment, and individual life experience, And people use substances or engage in behaviors that become compulsive and continue despite harmful consequences. And prevention efforts and treatment approaches are successful, just like for chronic diseases like diabetes, hypertension. And I've seen that all the time. Brain dysregulates, and people don't even realize. I told a patient one time all the consequences associated with his substance use, and he just said, "I know, and I really don't care." He said in a mean way, but they just lose control of their life. It's a behavior that continues. And they are trying, and we need to help them. But it's important here to know there is not because they are weak, it's because of the way neurotransmitters, the reward system, substances increase the dopamine release. There is neuroadaptation that results in sensitization and tolerance. And that goes back, and it's a circle. Especially during the adolescence, changes are very dramatic. And there is a video, you can listen to the video about how opioid use disorder changes the brain. Stages of addiction. There are three stages of addiction cycle linked to three domains of neurocircuitry, mediates three domains of dysfunction. And we have the binge intoxication stage, when the dopamine, there are surges of dopamine, and drugs are positive reinforcing. People feel high, have euphoria, depending on their tolerance. So this is regulated by the basal ganglia. And then there's the withdrawal, the negative effect stage, where there is neuroadaptation with negative reinforcement. People use drugs to feel better, to stop the symptoms. Preoccupation is the last stage, preoccupation anticipation, and that is the prefrontal cortex executive dysfunction, when there is total loss of control over drug taking and cravings. Many people do not know the difference between the opiates and opioids. So not all opioids. So opiates are the natural alkaloids that are found in the poppy plant, like morphine, codeine, and thebaine. Thebaine is not really used recreationally. People use thebaine to make other drugs, such as buprenorphine. Opioids are more. They include the opiates, the plant-derived, the semi-synthetic opioids such as hydrocodone or heroin, and the synthetic opioids. And the semi-synthetic are like heroin, for instance, is synthesized from morphine, while the synthetic opioids are totally made in laboratory. There's no natural opioid derivative. So that's why we say opioid use disorder, not opiate use disorder. So the synthetic opioids are can be very potent. The narcotic is not a term to use. It's best to use in a legal context, because it can be a lot of things, like cocaine, poppy straws. So just use opioids in general. Most people are not going to be using morphine. Most people will be using semi-synthetic or synthetic opioids. Kratom is a novel. It's a drug, it's a plant, but has a psychoactive, the alkaloid mitragynine, which is a mu opioid receptor 10 times stronger than morphine. However, this is made into a drug product, the plant, into dietary supplement, food additive, and it's sold online. You find it, you can find it online, in gas station, in a lot of places. and most at low doses is like a stimulant, but at higher doses is consistent with it has an opioid effect, and there's no antidote. Now, I didn't see many people withdrawing seriously from kratom, but kratom used in combination with other drugs can be fatal. It's not controlled, it's unscheduled by the DEA, and it's legal to cultivate, buy, and possess. But there are warning concerns because of the concentrated 7-OH products found in those tablets, gummies, the drink mixes. And in some substances, in some countries, is a controlled substance. Xylazine is one of the worst possible novel drugs, and it is a veterinary drug, and it's not for human consumption. So it's just like clonidine. It's an alpha-2 adrenergic agonist. That's the structure. So leads to peripheral vasoconstriction, activates peripheral alpha-2 receptor. So when people inject xylazine, they can have tissue ischemia, skin necrosis, infection, and I put in here some photos about that. Lots of people don't even know they have the xylazine in their fentanyl, and it's hard to detect. There are xylazine test strips, but typically you don't find it in regular urine drug screens, and it's an adulterant, and they do not know, most people do not know what it is. And it's sad because I had a patient who was using xylazine initially unintentionally, and then wanted to get help for not using fentanyl, but had no intention to stop using xylazine, despite the fact that had osteomyelitis, all the skin necrosis, the effects, the euphoria was something that he wanted to continue. And I also included a video in here, so you can look at that. So basically, when it's used as an adulterant in heroin or cocaine or fentanyl, it enhances or prolongs the effect of the drug, the fentanyl, for instance, or just increases the strip value by being heavier. This is the DSM-5 text revision classification opioid-related disorders. So there is opioid use disorder, intoxication withdrawal, opioid induced mental disorder, and unspecified opioid-related disorders. Opioid use disorder, this is the DSM-5 text revision diagnostic criteria. So basically you have to have a pattern of opioid use within a 12-month period that leads to clinically significant impairment or distress, and you have to have at least two of the following. So I have patients who've been using substances, opioids, but they didn't have these 12 marks period, so I could not really give a diagnosis. But typically you would see tolerance, the need for greater amount of opioids to achieve intoxication, or withdrawal, which is it's the characteristic of withdrawal. I'm going to talk later about that. Specifiers, there are lots of specifiers in early remission. If they use the sustained remission, they have to have like 1 year of not using. Early is like 3 months to 1 year. And maintenance therapy, if they are on methadone in a controlled environment, if they are in a place like where I work, where they cannot really use drugs, unless they sneak it in, but they should not be doing that. Specificity is mild, moderate, and severe, 2 to 3 symptoms. So it's based on the symptoms. Assessment and diagnosis. So we have the national practice guidelines, comprehensive assessment, medical history, physical examination, some laboratory tests. It's multidimensionally, and mostly you look at a diagnosis based on patient history, comprehensive assessment. Of course, you look at laboratory tests, and not all the drugs will show positive for opioids, because remember, you have to do specific tests. Mostly it's going to show opiates like the morphine, the codeine that I talk about. Opioid intoxication, people just use the opioids. They have pupillary constriction, so tiny pupils, drowsy, slur speech, and impairing attention or memory. Overdose is different. Intoxication is not life-threatening, while overdose can be life-threatening and needs immediate treatment with Narcan. So there's a spectrum too. It's a spectrum from mild to moderate intoxication to severe intoxication and overdose. And that depends on a lot of things, such as the level of tolerance to opioids, type of opioids. They use fentanyl or they use morphine that's not as strong. The route of administration, they use it intravenously versus by mouth. Or other substances that can add to that, like use the kratom that I mentioned earlier. But basically, it's altered mental status, drowsiness, sedation, and respiratory depression, typically less than 12 per minute, and pulmonary. Treatment, if it's mild or moderate, you just watch them, short half-life. You observe for a few hours, but it's longer half-life, like methadone, have to be longer observation, like 48 hours. But severe intoxication, it's a medical emergency that requires immediate intervention, which is Narcan. So if you suspect opioid overdose, such as drowsiness, low respiratory rate, person is difficult to arouse, give Narcan. So Narcan is a mu-opioid receptor antagonist, FDA approved for treatment of opioid overdose. Has a very rapid onset, but is short acting. So you have to repeat it in 2 to 3 minutes, but you have to call 911. Depends on the duration of the drug, the half-life. People need help, so it's gonna wean off fast. So you got to get help, call 911, but start with Narcan. Narcan should be given to people, we give to all of our patients who have a substance, has a history of opioid use disorder. Like people in prison, for instance, when they get out of prison, they are given Narcan if they have an opioid use disorder. But if they don't respond, the patient doesn't respond to Narcan, may think about, may not be the opioid overdose, maybe something else. Withdrawal is the opposite of overdose. You have large pupils, so mydriasis, pupillary dilation. You have goose flesh skin, sweats, nausea, vomiting, diarrhea. People are angry, irritable, lots of yawning, don't sleep well. How it looks is different for short-acting substances. Opioids, they peak fast, they clear like in 5 to 8 days, while the long-acting, like methadone, they start later and they peak later and may persist for longer time, for several weeks. Symptoms are typically not life-threatening unless there is something else, like there's medical disorder, something that complicates that. What we check it with the opioid withdrawal, look at clinical opiates withdrawal scale, and you see the word opiates. That probably needs to be changed to clinical opiates withdrawal scale. And if it's typically moderate, 13 to 24, that indicates need of medications. General supportive measures. This is good to treat patients, but opioid withdrawal management without ongoing treatment of opioid use disorder is not recommended because of the risk of return to illicit drug use and safety, like overdose and death. And it's always hard for me to put like risk of return to illicit drug use, because a word that we should not be using is relapse. So instead of relapse, I'm using return to illicit drug use. So the goals of opioid withdrawal treatment is to make patients feel better. That's why you assure them that you take their symptoms seriously, and then always provide harm reduction education resources about Narcan. Uh, to know how to treat opioid related disorders, you need to know some pharmacology about opioids, and that's an agonism spectrum. I included some brief videos in here that shows that they can show in simple words how they act. So there are three receptors, a type of receptor in the brain: mu, delta, kappa. Mu is the most addictive one. So the opioids bind and activate these mu receptor types. The agonist, full agonist, for instance, like fentanyl or methadone, they readily bind to an activate receptor and generate effect. You see where is on the graph in there. The partial agonist, like buprenorphine, they bind to receptor, activate them, but generate little effect and have a ceiling effect, meaning that it's difficult to overdose, to be intoxicated because of that ceiling effect that block receptors from occupation by other agonists and antagonists. And antagonists are the naltrexone and naloxone, the Narcan, naloxone, Vivitrol, and they do not activate the receptor, but they block the effect. And then you have the mixed partial agonist antagonist, which is like Suboxone, the combination buprenorphine and naloxone. So back to opioid withdrawal, the pharmacologic treatment. The first line is with buprenorphine or methadone, and then the methadone would be a gradual taper. You typically see that in opioid treatment centers. The buprenorphine is what you typically use, and typically you wait for objective signs of withdrawal. I typically you wait 1 to 2 days. If you are inpatient, you can wait a day. Outpatient would be like 2 days because it can cause precipitated withdrawal. So you start with like 2-4 milligram, titrate up, and then duration is like 4 to 7 days. The methadone, you got to be careful with methadone because of all the drug to the interaction, the respiratory depression. So now a new thing that happened was the exception, lots of legal requirements, restriction. The 72-hour rule, the clinician can prescribe methadone may administer the methadone in outpatient practice while arranging ongoing care, like sending patients to a licensed OTP. So then you have the adjunctive medication like alpha-2 adrenergic agonists like clonidine, which is actually use of label. Lofexidine prescribed. I have never used lofexidine. I use clonidine quite often when people are withdrawing. And then you use the other adjunctive medication like treat symptoms. You treat diarrhea with Imodium. You treat, you look at the symptom. You treat nausea with Zofran. But some people I put in there down that they try to self-treat themselves, and there they use kratom. They think that's gonna help, and it helps some, but it's still not getting an opioid withdrawal evidence-based treatment, and has lots of complications too. Opioid-related disorder practice guidelines. So there were those practice guidelines of the APA in 2006, and ASAM added the guidelines in American Society of Addiction Medicine in 2015. Then they did a practice, like a focus update in 2020. And basically they added some major revisions to existing recommendation, and they added some new recommendation. Opioid overdose, naloxone, number one, provided patients being treated for a history of overdose opioid use disorder. Opioid withdrawal, how you treat with buprenorphine and methadone, taper dosing and supportive. And then maintenance, methadone, Suboxone, or Vivitrol, not naltrexone. They use the Vivitrol, the injectable. But methadone and Suboxone are first-line medications. Psychosocial concerns are some of the new additions. Motivational interviewing, I use that all the time at work. It's really important to use it. Address the concomitant prescribing of benzodiazepine. Use it with caution, but this is not a reason to stop the treatment, to not treat the patients if they are using benzodiazepines. There's no recommended duration. That's a new one for pharmacologic treatment. Naloxone again provided. Non-pharmacologic treatment, motivational enhancement therapy, patient center is extremely important. CBTs, there are individualized psychotherapy, family involvement, self-help group. And again, look at the stigma. Be careful of how you talk with your patients. How we choose the medication, it depends. Depends on a lot of things. Look at patients' preferences, but also look at how sick they are. Like somebody with respiratory depression, I would not prescribe the methadone. I'll go with buprenorphine. Treatment settings, they need to be treated in inpatient or outpatient. History of overdose, you look at a lot of things. So when you look at inpatients, the ASAM criteria addresses 4 levels of care, how you treat the patient. Outpatient, intensive outpatient, and partial hospitalization, residential inpatient, medically managed intensive patient services. So OBOT settings are not as structured as OTPs, but they are very important, and most buprenorphine is prescribed Suboxone in OBOT settings. Buprenorphine, there have been milestones for treatment access, and initially just physicians were allowed to prescribe. Then we had the X waiver, and I had that. I got it right after. And then the Consolidated Appropriations Act eliminated these federal requirements of the X waiver. So now prescribers who have a DA registration that includes Schedule 3 authority may prescribe buprenorphine based on their state law. So look at the state laws, that's very important. And then you need some training, like at least 8 hours on opioid or other substance use disorders. Again, the ASAM criterion level of care. So you see there how it is. Level 4 is the one like when I'm admitting patients to my hospitals, I have to look, do they need to be in level 4 inpatient? They really have to be sick to be there, or they may just be treated in level 3 or 2 outpatient. So you got to look at the criteria where they belong. Opioid use disorder treatment with naltrexone is a mu opioid receptor antagonist, so it's a blocker. So you have to wait 7 to 10 days. If they use methadone or buprenorphine, I would use maybe 2 weeks, 10 to 14 days. Extended release is the recommendation right now, the Vivitrol, not the oral treatment, and is no. They do not need providers, prescribers don't need a DA number for that. Not a controlled substance. The methadone is a full mu opioid receptor agonist, and you got to look at the black box warning. The QTC prolongation, respiratory depression is a big one. Common adverse effects, and I have a lot of people with constipation. Not many have drowsiness, plenty have sexual side effects. And the drug-to-drug interaction, you got to be careful what you prescribe. I'm looking at all the medication like Seroquel, yeah, can prolong QTC. Abilify, aripiprazole will be better if you use, if you have to use And antipsychotics for SSRI, for instance, do not give Celexa. Citalopram is the worst for QTC prolongation. And then you look at the half-life. Methadone has a long half-life, so you got to be careful to not do it fast because people can overdose if they do it too fast. Buprenorphine, it's a partial mu opioid receptor agonist and has high affinity for mu receptor, displaces these full opioid agonists like fentanyl or buprenorphine from these receptors, and then it precipitates withdrawal. But it has that ceiling effect that prevents the overdose. It's important to look at the bioavailability. So given orally, it's not that effective because of its first-pass metabolism. So you got to tell the patients how to use it sublingually. Some people just take it, swallow it. They think, I'm going to swallow it. Typically, I prescribe it at like 16 milligram. Most of the receptors are occupied at 16 milligram, most of the mu opioid receptors. And started when the patients have objective signs of withdrawal, opioid withdrawal, unless they got out of prison, and they exceptions would be one an exception, and they've been there for a long time, not supposed to use opioids in prison. The drug-to-drug interaction, pharmacodynamics, drug effects on the body, potency, how strong is the, how potent, strong the drug. So fentanyl is very potent. So now keep in mind that opioids interact with antidepressants, so medication for migraines, because it can cause serotonin syndrome. The respiratory depression, if they use it combined with like benzodiazepine or other depressants such as gabapentin, Neurontin, Flexeril, sedating medications. So there's a synergistic effect by itself, like they would not do much damage, but if used together, a benzodiazepine or an opioid, like alcohol or opioid, the effect would be much, much stronger. I included here a little table of how you would select the medication, the mu opioid receptor. You see methadone is full opioid, buprenorphine is partial opioid agonist, Vivitrol is opioid antagonist, and then you can read that, the blockade. For pregnant women, it's very important to treat them as soon as possible. And there are physiologic changes that occur during pregnancy, and they can alter the buprenorphine method of metabolism. This is one time, and I go higher than 16 milligrams. I give 24 milligrams of buprenorphine to pregnant women because during their third trimester of pregnancy, because of the increased expression of this cytochrome SYP3A4, this leads to increased metabolism of buprenorphine and methadone. And patients typically need higher doses and increased frequency of dosing. They're going to have the baby, you go down to the dose they were. Here I included a video with best practices for buprenorphine treatment. State laws, this is a very complicated issue. In a lot of states, substance use during pregnancy is considered child abuse and neglect. Some states require healthcare providers to report suspected maternal use to protective services. Now, North Carolina, for instance, doesn't require, but you can do it if you want. Virginia required at one point to report it. So some states mandate drug testing, and the problem is if pregnant women are afraid that they are going to get tested and somebody's going to treat them again, stigma, self-stigma, they're going to may lose custody. They are not going to get help. They are going to try to hide their substance use, which can be worse. And studies show that it got to worse outcomes. Adolescents, you treat adolescents too. Typically, adolescents are in a way like pregnant women. They don't want to go there because of the stigma. So stigma is from providers. Stigma that medication should not be offered to adolescents. So it's important to educate the adolescents and the family because that's the time when damage happens. Remember, the prefrontal cortex is not fully developed, and the brain can be damaged at that time. Older adults, Suboxone, buprenorphine, naloxone offer it first line, methadone second. Well, elderly have higher sensitivity to substances, are at risk for fall, susceptible to disorientation, and the methadone can do that. Respiratory depression plus methadone is really excreted, and elderly may have impaired renal function, and then the people with liver disease may have decreased metabolism, so slows the metabolic clearance of methadone. A recommended dosing approach is to start low and go slow and use the lowest minimum dose, lowest effective dose. Chronic pain, first of all, find out what type of pain patients have. Pain is really a symptom, not a specific diagnosis. So you have to find a diagnosis to be able to treat the pain. Remember, number one source of why people use pain. While the risk of death from overdose is recognized risk from opioid use disorder, look at other things. The risk of suicide in the setting of chronic pain, when pain is not adequately managed, studies show that it's 7 times higher the risk of death from overdose. Harm reduction strategies, so provide overdose and naloxone education, address infection prevention like TB, treat the infection, supervised consumption facility. We have some, like New York City opened the first facility. Fentanyl and xylazine tested housing options. Offer patients, try to find a place for them. Look at the houses that offer the housing for people with addiction. And medications like methadone or Suboxone. Risk mitigation, the prescription drug monitoring program, check regularly and shows you if patients are using using other substances like benzodiazepines. Opioid treatment agreements can also be done. Urine drug screen. Immunoassay, do not check for everything. So if somebody tells you, oh, they tested negative for opioids, it's not really, they tested negative for that opiates. Remember, targeted to detect opioids using morphine for the target, which is the natural morphine. So anything that's metabolized to morphine like codeine and heroin will be detectable on urine drug screen. But some detect semi-synthetic, they do not detect synthetic opioids. So it depends on what, like for instance, oxycodone would not be detected, buprenorphine would not be detected, methadone. So you got to specifically check for this. So if somebody, fentanyl would not be detected. So if somebody says I use fentanyl, but the urine opioid immunoassay is negative, that doesn't mean that they did not, that they lied, because fentanyl is a synthetic substance. Continue to resume use. So look again, the definition of addiction: treatable chronic medical disease, complex interaction, brain, circuits, genetics, environment, and the life's experiences. And people have behaviors that become compulsive and continue despite harmful consequences. So remember, you can treat just like diabetes and hypertension, and try to build a therapeutic alliance. That's how you work with patients. And keep in mind when you prescribe opioids, though, that all the medication, all the opioids carry the risk of development of addiction and diversion, and so don't prescribe it for someone who would not need it. And here are some case studies, like this guy, for instance. He told me that he used 20 to 30 fentanyl pills or 1 to 2 gram fentanyl and heroin daily by inhalation, and he used it today. Said that he was treated for opioid withdrawal 8 times this year, last time this week. Said he took buprenorphine outpatient last time a few months ago, and he wanted to start buprenorphine. Now, I didn't think it was necessary for him. So the prescription monitoring, the PDMP, the drug monitoring program, showed that he indeed had buprenorphine. So he was right, but he got it in an inpatient setting, not maintenance. Urine dioxin was negative for all substances, and I checked for everything: opiates, oxycodone, fentanyl, buprenorphine, methadone, morphine. He had some, restless, falls asleep during assessment, has rhinorrhea. So the diagnosis, yeah, it may be opioid withdrawal, but not necessarily. Maybe kratom withdrawal. Who knows what he's been using? Who knows what it's in what he's been taking in the pills that he's using? Obviously, was not fentanyl, not buprenorphine, methadone, oxycodone, not an opioid that I would detect. So was treated with clonidine taper, and then eventually got better and was discharged. The other patient was using 1 gram heroin, fentanyl, cocaine by IV. Now, the first patient didn't have any track marks. So I couldn't see any track marks. He was using inhalation, so another sign you look at. This guy so had multiple track marks, very thin, heart rate was high, he was skinny, blood pressure was elevated, he was on methadone, which I verified. So the urine dioxin was positive for amphetamine, methamphetamine, cocaine, methadone, and fentanyl. He said he did not use methamphetamine and amphetamine. Now, obviously, looking at his BMI low, the elevated blood pressure, high rate, you probably would assume that yes, he's using stimulants, but he did not know. And I believe him. Who knows what's in that fentanyl or heroin or cocaine that he's been using? It may be methamphetamine. I have patients who overdose just because of cannabis. They had fentanyl. So people don't know what they are using, the adulterants in there. This patient used methamphetamine, amphetamine. So that one had discoloration and pitting edema of legs, skin sores, red fluid leaks out of her sores. He thought a bug bit her. It was actually xylazine. Again, you cannot test for xylazine, not unless you have a specific test. We don't have it. It's a fentanyl strip test. But the skin sores on bilateral lower legs, the pitting edema. So you actually treat the xylazine kind of, you can give muscle relaxant like a Valium. You treat the fentanyl with clonidine. She was on methadone, so clonidine helped. The next patient using Xanax and opioids had take homes and missed the doses. The clinic cut him down because he was using a lot of Xanax. Now, this poor guy, he's so young, he's 22 years old, and he didn't have any more veins. Poor vein access. He used fentanyl, had poor vein access, could not inject anymore, so he started inhaling. Then he got perforated nasal septum, so he couldn't inhale, so replaced it with Xanax. And he had signs of benzodiazepine withdrawal, dizzy, weak, slow down, the cognitive impairment, the spacey look. So urine dioxin was positive for methadone, marijuana, benzos, and negative for fentanyl, was using a sedating medication, gabapentin. And just put in there so you know, at this age, he already had hepatitis C, hepatic steatosis, had seizures, endocarditis, and sepsis. So this patient told me that he was using 90 milligrams of methadone and used it yesterday, and I didn't have any records. So when I looked at the records, I noticed he got methadone 99 days ago. So why wouldn't he tell me the truth? So then again, you look at the not being stigmatizing. So you'd ask what happened. Because initially he lied. He said, I used it yesterday. I said, well, okay, I talked with your clinic and they said you didn't get it, you haven't been there in 9 days. What happened? Oh, I went to jail. So they didn't give it to me in jail. So anyway, trying to be open-ended question like what happened. Don't say, did you lie or anything. You have to show that you are non-stigmatizing, because what would be the reason for the patient to not tell the truth? Withdrawing heavily. He wasn't feeling good. So detection time of urine dioxin, methadone, it's longer, 5-7 days. Fentanyl, it's about 2 to 3 days, somewhere there. So he asked to get 90 milligram methadone. Would you give it to him? No. He used 90 milligrams 9 days ago. You got to cut down slowly, slowly. There's a rule. And I would start him with 30 milligrams. Sometimes people start with 20 milligrams, and then you go up a little bit, not 90. You can kill a patient. So this one was unresponsive. Again, homeless shelter is house, not homeless. She had all the symptoms of opioid in the opioid overdose and got naltrexone. Look at the respiratory rate, pupils, and so opioid overdose, the diagnosis, and naltrexone. Later, when she woke up, she was alert, wanted to leave. She was totally normal. What would you do at that time? Could you involuntarily commit her? No, because she's alert. She knows what she's doing. Yeah, it's a poor choice, very bad choice. She can overdose. All you can do is educate, but you have no grounds for involuntary commitment. Now, this one was asking to give her buprenorphine that day, or she'll call the patient rep, and she was actually, urine oxygen was positive for fentanyl morphine, so full opioids agonist. Give a buprenorphine, would put them in precipitated withdrawal. Do not give it. Wait for like 2 days. Give clonidine, help with some Valium, but don't give that. And the last one, so this one was using methadone, didn't want to get out of the bed, messy, trash everywhere, was full of urine, didn't want to change, didn't even want to get out when there was a fire alarm. So staff even saw it was a real fire. Signed 72 hours and demanded to be discharged immediately. And the note of discharge expired in 3 hours. Now, this is a patient that you can involuntarily commit because she doesn't seem like she knows what she's doing at that point. Her actions. So you have grounds for commitment. Bed full of urine, didn't want to get out, there was a fire. So you got to look in the context. And these are my references. And this was my presentation for today. Thank you very much.
Thank you, Mihaela.
I don't know if I have any questions or I don't see.
No, I don't think we have any students here at the moment, but we'll have this posted for them to
Recorded.
view later.
All right. Well, I'm glad we are able to do it. Thank you very much.
Yes, yes. Thank you again. Very good information.
Thank you. Bye.
Bye-bye.
Bye.